I'm an ML expert. I have got a certification in ML learning. So essentially, sir, CAD in Indians is a different animal. It is a disease associated with a lot of inflammation. Early CABG failures have been historically linked to anastomotic site stenosis and generally surgical technique. It may also be related to the progression of atherosclerosis due to pre-existing risk factors. It may be influenced by the operator experience, surgical experience, also by the type of the surgery. Is it off pump or on pump? And by the conduits that are used in the CABG. So we need to continuously analyze for the other factors that may influence the early failure of CABG, especially inflammation. So our study aims and objectives was that is there something beyond technical failure? It was to analyze the demographics, the patient and the operative characteristics. We have seen the clinical features of patients who are undergoing early reintervention of the CABG, which was arbitrarily defined as within 2 years for this study of the index primary CABG. Primary CABG here meant that there was no past PCI or a CABG done on the same patient as per the Magnus-Dahlen study, which is another study like this. We have used both like logistic regression and machine learning for this to determine the predictors of early failure, and we have created a composite risk prediction model for this and we have also done a forward-looking validation cohort for this. So we have studied 1, 3, 6, 7 patients who underwent CABG as the first intervention in them from Jan 1, 2001 to December 31, 2015. All the CABG were done by 3 operators in our hospital, 2 more from Puttaparthi, 5 totally with an experience of more than 100 procedures per year, with expertise in both off-pump and on-pump CABG. We have seen the patients who underwent any past revascularization and we have excluded them, and we have done a validation data set of about 28 patients and evolving, which was done after 2016. So in the overall data, we found out that the average age of these patients, 160 patients actually got it out of 1367. That is about 11.7% patients underwent a reintervention within 2 years, which is quite high compared to earlier studies of around 4.5 to 5.5%. So in them, the age was 57 years with a male dominance, with more people being hypertensive, diabetes. We found a dyslipidemia pattern of HDL being low in almost 1/4 of the patients. Family history of CAD of 37%. Smoking and prior MI was also seen. COPD was seen in about 3 to 4% of people. In the overall cohort, we found a CVA of 2.5, PAD and carotid disease of around 37%. So we had quite a bit of patients having the peripheral arterial disease also. We found the HbA1c in them was 8.9, quite uncontrolled. LVEF was 47%, and we also got a slightly higher range of serum cholesterol, serum creatinine. We also got significantly CRP more than 5, N/L ratio of more than 5 in these patients. We have done around 11.7%, as I said, who have come within 2 years of the first CABG. As per the anatomy, new lesions on CAG were seen in 25% of these patients, up to 75% were in the prox and the mid LED. SVG graft was the commonest anatomical lesion, which was found in about 75% of people. Of the 160, what did we do to them? 134 underwent a next intervention, that was 125 PCI, 9 of repeat CABG, and 26 were managed medically. So when I did a univariate analysis on them, early intervention without, like after CABG and no early intervention, we found out that among the other factors, diabetes and a higher admission sugars of more than 300 were more likely to become a risk factor. Also dyslipidemia, that is HDL less than 13, 77 versus only in 36% in those who were not requiring an early intervention, and the others were active, like smoking history. OPCAB was almost 77% in people who were not having, who had required an early intervention, versus 57 who were not requiring early intervention. We have studied the residual syntax score, which was almost twice, that is 21% in those who required an early intervention again. Like in terms of conduits, the bilateral IMA, Lima, and the free REMA did significantly well, with almost 23% requiring early intervention, while no intervention was seen in about 46% of people. Serum cholesterol was not reaching significant levels, but we have also got serum albumin and CRP much higher, which is seen lower down on the table. In terms of multivariate predictors, when we had got that if people have renal dysfunction, that if the serum creat was less than 1.5 versus more than 1.8, less than 1.5 versus more than 1.8, it was much likely to be portending towards a early reintervention. AF was more likely to be like a predictor for reintervention. Uncontrolled DM continued to be in the multivariate analysis. if the patient had a past anterior wall MI and then underwent a CABG, if the number of grafts were more than 4, if there was a radial graft, I'll just come to that next, and if there was a low HDL less than 30. So if there was an RCA graft, if the number of grafts were more than 4 down there, and along with this, all the other factors, that is uncontrolled DM was actually the highest value based on the weightage as per the hazard risk was 4.5, AF was 4, if there was renal dysfunction, if the creatinine at discharge was more than 1.8, or it required renal intervention, 3, a past anterior wall MI of 2.4, and if there were number of grafts more than 4, or if there was an RCA graft, especially an SVG graft here, was twice more likely, and HDL less than 30 was twice more likely. In terms of precision recall analysis, we have seen that it was almost 65% likely with this model to give you a chance of somebody requiring a second intervention. And the area under the ROC was 0.68, which is like moderately acceptable. All these patients are not a bunch of statistics. We have tried to do machine learning. Machine learning essentially does not cause any sort of a projection. It sees all the variables. We actually create a kind of a heat map. This is what we do. In like logistic regression, we only think about the likelihood and the consequence. We don't bring in people there. So when we actually bring in people with the machine learning, that is, we see each variable against the other. I had spoken about this yesterday also. It needs to be taken in perspective that all our risk scores do not do this. They see it in terms of a linear regression, because see, a regression analysis sees only a linear correlation. It need not happen because a patient can be having age and have like more than one risk factor. Even a multivariate analysis does not really work like well when there are more than 5 or 10 risk factors. So when this was done in this patient, we created a heat map, that is, each variable studied is against the all other 25 other variables. And when this was done, we got a better analysis. I'll just skip this slide because the next slide is more clear. This is all the parameters that we got, which was index admission. So the sugars still continue to remain a very, very important factor, along with the patient requiring a post-op, like a renal insufficiency or requiring dialysis. If he needed an RCA graft or a diagonal graft, CBG more than 4 grafts, CRP was important, albumin less than 3.5, all these are the inflammatory markers. Off-pump CBG was more likely to fail, and of course SVG was more likely to fail versus the total arterial. In terms of area under the ROC, it is much better to do it in terms of like in machine learning than we go for a logistic regression. So the conclusions were there. Uncontrolled sugars are an important predictor of early failure. Though we do not have any local data completely on follow-up, we have up to about 3 years of follow-up of this. We need to go further. An additional diagonal and RCA graft is more likely to fail. Total arterial is best. Inflammatory markers need to be seen in every patient because they actually portend to early failure. It's not just the graft failure, it's also inflammatory markers. And of course, emergency CBG didn't do too well. Actually, a lot of these patients had inability to tolerate statin. Statin continuing was actually protective. And of course, we can always say that ML learning as per the AUC was actually better than the regression analysis. Thank you, sir.